don't see much of this in Utah. And then drugs and toxins. I think everybody's familiar with fen-phen. Other stimulants, amphetamines, methamphetamine, quite a problem with that in the Intermountain West. Very strong risk factors for pulmonary hypertension. Cocaine, L-tryptophan, which I don't think you can get the particular L-tryptophan anymore. So here's our current classification. As I mentioned, we'll upgrade at the Dana Point meeting this summer, but has been under the Venice classification classified as 5 different groups. We call these WHO groups, World Health Organizations. Group 1 is where we spend most of our time. We call that pulmonary arterial hypertension, whereas the rest of these we call pulmonary hypertension. But in the WHO Group 1, idiopathic, familial, which is associated with the BMPR2 gene mutation, associated with collagen vascular disease, that sort of thing, and then associated with significant venous or capillary involvement. Very rare diseases and very difficult to treat. Usually involve some form of transplantation. Most of our patients will present with WHO Group 2, WHO Group 3 disease, and there's not as much data on what to do with these patients. There's data coming out, patients with primary lung disease, patients with primary heart disease. There's data coming out, but we still don't have data like we do in WHO Group 1 patients on the natural history, how to manage them, and what medications to use. So, pathophysiology of pulmonary hypertension. We think, people have risk factors, maybe collagen vascular disease like scleroderma, congenital heart disease, portal hypertension, HIV, drugs, pregnancy. And then there's probably some other factor, a genetic susceptibility like the bone morphogenic protein receptor 2 abnormality or the ALK1 abnormality that you see in hereditary hemorrhagic telangiectasia. These factors combine to result in some form of vascular injury. We know there's a lot of endothelial dysfunction. We know that the vascular smooth muscle is involved. You start getting thickening of the vascular smooth muscle, as well as thickening of the adventitia and the endothelium. Ultimately, disease progresses. You start getting obliteration of the vessels, increases resistance to flow, backs up into the right ventricle. You start developing right ventricular dysfunction and failure. So, what does occur linearly is an increase in pulmonary vascular resistance. And I tell people pulmonary hypertension is not a problem with pulmonary pressure. It's a problem with pulmonary vascular resistance, which adversely affects cardiac output. People feel the decreased cardiac output, particularly with exercise. They don't really feel any particular pressure. You'll see people with pressures of 90 that can walk around and people with pressures of 40 that are disabled. And it has nothing to do with the pressure. It's really the cardiac output and the function of the right ventricle. Right atrial pressures will increase throughout the disease progression, and pulmonary artery pressures will progress to a point when the right heart starts failing, they'll actually start going down. What happens molecularly? There's 3 primary pathways that have been implicated, mostly for their treatment modalities. But the nitric oxide pathway, arginine is converted to nitric oxide by endothelial nitric oxide synthase, activates soluble guanylate cyclase. Cyclic GMP goes and downstream signaling results in smooth muscle relaxation and anti-proliferation. In pulmonary hypertension, this nitric oxide synthase is downregulated for unclear reasons. The endothelin pathway, endothelin is one of the most potent vasoconstrictors that we know of. It's implicated in many diseases, to include left-sided heart failure, subarachnoid hemorrhage. But pre-proendothelin is converted to endothelin by an endothelin-converting enzyme. This endothelin activates endothelin type A and B receptors downstream, leads to smooth muscle contraction and proliferation, which is a pathologic response. In pulmonary hypertension, that is upregulated quite significantly. And then the last pathway, the arachidonic acid pathway. Arachidonic acid is converted to prostacyclin by prostacyclin synthase, activates adenylate cyclase, ATP, cyclic MP downstream, smooth muscle relaxation, anti-proliferation, and in pulmonary hypertension, that prostacyclin synthase enzyme is downregulated. Well, here's the data that we're probably familiar with from the NIH registry that was accumulated in the 1980s, published in 1991. Shows that what they used to call primary pulmonary hypertension has a very severe natural history. If you follow these patients out just over 3 years, more than half of those patients are dead with a median time to death of 2.8 years. So this is worse than a lot of our cancers, including lung cancer. This was before we had treatment. Remember the New England Journal article published in 1996 looking at Flolan. If you have collagen vascular disease like scleroderma, it's even more concerning. If you just have scleroderma by itself, go out to 10 years, most of these patients are still alive, and scleroderma patients are doing better and better with our rheumatology interventions. If you add lung involvement, interstitial lung disease, it drops off, but it's still, you're still looking at most of these patients being alive out to 10 years. Throw in pulmonary hypertension with scleroderma, and it's devastating. Half these patients are dead just right around a year, a little over a year. And pretty much nobody has a long-term survival with pulmonary hypertension associated with scleroderma. This study was just published in February. It kind of looks at it a little different way. They looked at the patients in the dark blue here just with pulmonary hypertension and scleroderma, and these are patients who were all treated. Most of them were on bosentan, better than the historical data. A little over 60% of patients alive at year 3. Add interstitial lung disease to the pulmonary hypertension. We have quite a few of those in our clinic, and the survival drops off. Still a very grim prognosis. It does matter what kind of pulmonary hypertension you have. If you have pulmonary hypertension associated with congenital heart disease, you do very well with or without treatment. If you have it associated with HIV, you do very poorly, and some of this is owing to the comorbidities of the HIV, but some of it is the pulmonary hypertension itself. Idiopathic pulmonary hypertension, still, we're doing better with it. These are treated patients, but still the mortality is quite high if you follow them out over several years. So what does the ACCP say about diagnosis and evaluation? Well, they say, is there a reason to suspect pulmonary hypertension? Patient has unexplained dyspnea. Well, if there is, you're going to get your history, exam, chest x-ray, and if pH is likely, too many buttons on this thing, if pH is likely, get an echo. The rationale is you can look at indirect assessments of pressure, chamber enlargement, and right ventricular function. You want to know if the pH is due to left heart disease. We may need to get one of our cardiologists involved. The echo can give us insight into that, whether you have LV systolic, diastolic dysfunction, valvular disease. And if you do, you're going to treat the left side of the heart first. Is there congenital heart disease? We order all our initial echoes with contrast, and the rationale there is we're looking for abnormal morphology, intraatrial or intraventricular shunts, right to left shunt, of course. We want to know if it's associated with collagen vascular disease or HIV. That has implications on the natural history of the disease. We'll order serologies. We sometimes diagnose de novo collagen vascular disease and refer to our rheumatology colleagues. Is chronic PE suspected? We'll get VQ scans on all these patients, and why not CT? Well, VQs have been proven to be much more sensitive for picking up chronic PE than CT scan. CT scans are good for about 50% of chronic PE, and a very different story for acute PE, but for chronic PE, CT scan is not very sensitive. So VQ scan, very high sensitivity in the 90s. We'll order those, and then if they're positive, we'll consider further CT or conventional pulmonary angiography. The reason for that is if they do have chronic PE and are a surgical candidate, this is a surgically curable disease. We want to know if it's due to lung disease or hypoxemia, and so we order a lot of pulmonary tests, PFTs, arterial saturations, that sort of thing. We'll look for sleep-disordered breathing, and if we have any of these pulmonary comorbidities, we'll optimize therapy. When these patients come in for follow-up, they all get clinical assessments. How are you doing? How are you feeling? What New York Heart Association class are they in? And how do they do on their 6-minute walk test? We can tell if they're responding to therapy, if they're heading towards needing therapy. And then we also need to know what the precise hemodynamics are. And we do right heart catheterization on all these patients before we start treatment. And the reason is that we want to know what the exact PA and right atrial pressures are, wedge pressures. We do look for left to right shunts, assess mixed venous oxygen saturations, cardiac outputs. People say, well, can you go by an echo? Well, echo is a good screening tool, and it's a good tool to follow these patients, but it doesn't have the accuracy for making medical decisions. There's a study that just EPUB'd, I think it was at a Cleveland clinic, and it's going to come into print here shortly. Pretty large series. They looked at echo. Half the echoes were right, meaning they were within 10 millimeters of mercury of the right heart catheterization. Half of them were wrong. The half that were wrong, half were too high and half were too low. And so it's a screening tool. It doesn't quite have the accuracy to make decisions in these patients. What kind of medications do we have? Well, we have the prostacyclins. EPO comes in inhaled iloprost. We have treprostinil that comes in intravenous, subcutaneous, and inhaled forms. Very effective medications, very expensive, they really take a lot from the patient. A lot of support, both in the family, support in the medical clinic. The oral agents have really revolutionized pulmonary hypertension. The endothelin antagonists, we have 3 of them out there. Cetaxetin's not available in this country, but ambrisentan and bosentan are. The phosphodiesterase inhibitors, sildenafil, tadalafil, sildenafil's been out for a while. And so the prostacyclins, again, going back to 1996, that seminal article published in the New England Journal, prostacyclins activate adenylate cyclase. The prostanoids can directly activate the adenylate cyclase, bypassing this downregulation of prostacyclin synthase. This was the study in the New England Journal in 1996. They took 81 patients with New York Heart Association class 3 and 4, what they called at that time primary pulmonary hypertension. Half of them were randomized to EPO and half of them to placebo. 6-minute walks increased 47 meters in the treatment arm, declined 66 meters in the placebo. Mean PA pressures down 8%, up 3% with placebo. Pulmonary vascular resistance down, up with placebo. No mortality in the EPO arm, 8 mortalities in the placebo arm. This is the first and only study that showed a mortality benefit in treating pulmonary hypertension. And I'm afraid we're not going to see placebo-controlled trials anymore because it's not going to, at least in this country, it's not going to be considered ethical to withhold treatment in a treatable disease. How about endothelin antagonists? The endothelin antagonists, again, activate the A and B receptors, causing smooth muscle contraction and proliferation. We have agents that can block the A and B receptors like bosentan, or just the A receptors like ambrisentan or cetaxetin, what they call the more selective endothelin antagonists. 2 studies. Study 351 was a pilot study. They looked at idiopathic pulmonary hypertension as well as associated pulmonary hypertension. These were class 3 and 4 patients, adults, pretty sick, 6-minute walk above 150, less than 500. Mean PA pressure had to be higher than 25, pulmonary vascular resistance greater than 3 Woods units or 240 dynes, and they had to have normal wedge pressures. This was followed up by the larger Breathe-1 study. Pretty much the same criteria, except they enrolled repaired congenital heart disease, and they went down to 12 years of age. This was a study 351, and Breathe-1 had similar architecture. Placebo-controlled, 2 doses of bosentan, 62 and 125 in one arm and 62 and 250 in the other arm. Went out to 16 weeks, reassessed them, and then did a follow-up out to 28 weeks. And pretty impressive. 6-minute walk distance increased with the bosentan therapy. The placebo effect, which you see anytime you teach somebody how to do a test, but they ultimately declined in their 6-minute walk in the placebo arm. 44-meter difference, highly statistically significant. New York Heart Association functional class, 43% of the patients in 351 and 42% of the patients in Breathe-1 improved to functional class. That means they went from New York Heart Association class 4 to 3 or 3 to 2. And that's how patients feel pretty much. It's a subjective assessment. In 351, they looked at hemodynamics. Everything went in the right direction. Mean PA pressures, mean right atrial pressures went down with treatment. Here we go. Cardiac index. So cardiac index went up with treatment. Right atrial pressures went down with treatment. Pulmonary vascular resistance went down with treatment, and mean PA pressures went down with treatment. Sort of the opposite effect in the placebo arms. clinical worsening, which is sort of a combined endpoint of death, hospitalization, or discontinuation of therapy, or the need for escalation of therapy. 89% of patients in the treatment arm did not require escalation of therapy or have complications. 63% of patients in placebo didn't meet criteria statistically significant. This is going to be a new criteria by the FDA in assessing new therapies for pulmonary hypertension, is showing that there's a reduction in clinical worsening. How these patients do over time, 2-year follow-up. If you look at patients with idiopathic or primary pulmonary hypertension out to 2 years, this is basically pharma data on their registry. 89% of the patients were still alive. Scleroderma doesn't do quite as well, but still better than the historical controls. And if you remember going back to the NIH registry, primary pulmonary hypertension, you go out to 2 years here, they're significantly improved on the new therapies. Now, whether this patient population is the same as the NIH registry, I think you can make a good case that they were different. Patients were much more advanced back then. But the hemodynamics, the mean PA pressures and all that were fairly similar, around the 50 mean PA pressure range in both the NIH registry as well as the newer pharma studies. How about nitric oxide? How am I doing on time? 5 minutes, okay. And we'll just blow through nitric oxide real quick here. So the nitric oxide pathway, again, arginine, citrulline, nitric oxide goes in, activates guanylate cyclase. This cyclic GMP, which is a signaling molecule, is broken down by phosphodiesterase 5. And the PDE5 inhibitors, like sildenafil, can increase guanylate cyclase by preventing this breakdown and give you the effect of smooth muscle relaxation, anti-proliferation. So sildenafil, first study was a Super 1 study. They looked at adult patients with primary and associated pulmonary hypertension or surgically corrected congenital heart disease. Mean PA pressures and all had to meet the same criteria for pulmonary hypertension. These were healthier patients than what we've seen in the Bosentan studies. These were a lot of class 2 and some class 3 patients. 49 years on the mean age. Most of them were primary pulmonary hypertension or idiopathic. There was some associated and some congenital heart disease. Pretty sick group, mean PA pressure of 53. They randomized to 4 arms placebo, 20 milligrams, 40 milligrams, and 80 milligrams of sildenafil 3 times a day, and they followed them out to 4 and 12 weeks. And all doses of sildenafil resulted in improvement in 6-minute walk compared to placebo. There was no dose response curve, no statistical dose response curve. The FDA approved 20 milligrams since there was not a dose response curve. Hemodynamics, there may have been some improvement at the higher doses, but since the patients didn't clinically do better, again, approved it at 20 milligrams. The extension study, Super 2, the patients from all 4 groups were entered into Super 2. Some of them were withdrawn. Patients that completed 1 year of treatment at 80 milligrams 3 times a day. They sustained the 6-minute walk out to 1 year. And if you look at their Kaplan-Meier curve, 94% of the patients were alive at 1 year. Pretty good if you compare it to historical controls. And we'll skip that slide. And these are my twins. This is right after their birthday party. They got their faces painted, and they're 5 now. And I'll take any questions.
How about use of calcium channel blockers like Norvasc or pulmonary hypertension?
Yeah. So we want to know if patients respond to acute vasodilators. So we use, in the cath lab, we use inhaled nitric oxide as a short-acting pulmonary vasodilator. If they respond, it predicts that they'll respond to calcium channel blockers. Only about 13% of patients respond to acute vasodilators. That's the population that would respond to calcium channel blockers. If you follow them out over time, half of them quit responding. And so ultimately, only about 7 or 8% of patients with pulmonary hypertension respond to calcium channel blockers. Patients with right heart failure, right ventricular dysfunction, or severe pulmonary hypertension can be harmed. They can develop refractory hypotension, and so it's a high recommendation from the ACCP that patients do not empirically be treated with calcium channel blockers. Unlikely to help them, could hurt them. Dr. Mosier?
I see periodically chest CT reports where they will, through the dilated pulmonary artery, suggest that this may well represent pulmonary hypertension. Is contrast chest CT, is that accurate at all?
Yeah, that's a very good question. Now, we do see that a lot, and the CT is pretty good. There are other things that can dilate the pulmonary arteries, like obstructive lung disease, for unclear reasons. But yeah, if you see that enlarged pulmonary artery, that is a surrogate of pulmonary hypertension, probably deserves to be investigated.
Thank you, Josh.